Hello students, this is Sharon Rayner and I am going to give a brief visual diagnosis overview, a guideline for making visual diagnoses in dermatology. These are our objectives for this talk, and really we're trying to improve your confidence in identifying some common rashes and also increasing your confidence in making rapid and accurate visual diagnoses for common rashes that you'll see in primary care. And it's important to be able to describe rashes and some other lesions, although I don't think we're going to get into too many lesions today, but to describe them and decide which type of rash or lesion you would want to refer, or that it would be okay to wait and see how the patient might respond to some treatment through primary care. I do want to point out before we get started, looking at some visual rashes, that we will cover some rashes. Of course, this is not an exhaustive list of all the rashes that you'll see. And also dermatology is covered in the whole clinical part of your program, so that common adult rashes, and then you'll cover pediatric rashes, and then also rashes and skin abnormalities that affect older adults in geriatrics. So whenever I see a chief complaint of a rash, I either think, okay, this could be very straightforward, or it could be very complex and involve a lot of time. In general, a rash is a non-specific term that describes any visual skin outbreak. And rashes are very common in all ages, from infants to older adults, and nearly everyone will have some type of rash at some point in their life that they will seek care for that rash. So in primary care, we have to be very vigilant in our visual diagnoses. The other important thing to remember as we're doing more telehealth and looking at things through video, it's very important to be vigilant. And patients will often diagnose themselves before they see you, like come in and say, I have poison ivy, I need to be treated, as an example. And you just have to be very vigilant in your history taking and in making the visual diagnosis. And so, as I said, I just see rash all the time in the emergency department or in primary care when I'm seeing homebound elderly. And it, to me, it triggers that, it's not going to, I always go to, it's not going to be a simple thing unless I prove that otherwise. And then the first two things that I start to think about are, is this rash infectious or non-infectious? And is it, a life-threatening rash, for example, like a Steven Johnson? Is it a drug-type rash? Or is it worrisome where I need to have, some more intervention right away? Or is it more of a benign, quote unquote, rash that I can, try some treatment and then see the patient back and go from there? And by benign, I don't mean to minimize any type of rash, because I want you to take rashes very seriously. But benign in terms of, I'm going to go ahead and treat this, and then I have some time to wait and see. I feel confident the patient's going to let me know if it's not getting better, and proceed in that manner. Now, one of the things I hear from students all the time is they either love dermatology or they don't love dermatology. They either want to build their confidence and really like dermatology, maybe perhaps want to go into dermatology. I've had plenty of students either go into medical dermatology or cosmetic dermatology, but or you're on the other end of the spectrum where you really dislike dermatology. And in full disclosure, you might start out not liking it because you don't have the confidence. As you look through some of these photos in this talk, everything starts to look the same. So your confidence level in differentiating things is not there yet, but you could grow to love it. And in full disclosure, I really like it. I mean, it's something that I don't want to work completely in dermatology, but it's fascinating because you never see the same rash that you're going to diagnose maybe as allergic contact dermatitis never looks the same in two patients, probably never. There are some emergencies where we need to have a patient evaluated. Only one time did I ever have the dermatologist come to the ER, and they did, and it was for a psych medication allergic reaction that probably was going to be diagnosed as Stevens-Johnson's. But for Stevens-Johnson's, that is an emergency. We'll talk about some life-threatening rashes that you definitely never want to miss. We call them critical rashes in the ER. But you really want to make sure that you are completely, like I mentioned before, vigilant about your diagnosis, especially your history taking, and then, you know, it's very fascinating to be able to diagnose and treat rashes and other skin problems. So as I mentioned also before I move on, important features to consider: is this localized? Is this generalized, meaning a whole body rash? That would make you a little bit more concerned about the rash. If it's itchy or not, so they're either going to be itchy or not, and you'll hear that all the time, like especially in urgent care. If they come in with an itchy rash, it's almost like immediately it's fine, treat them and have them go on their way, follow up with the primary. If it's a painful rash, or if there's a fever, or you see petechiae, things like that are more worrisome. And especially if it's chronic versus acute. So if you think about like eczema or psoriasis, I mean, these are common chronic kind of rashes. And so you have to begin to differentiate, you know, is something else going on with this patient, you know, because they will come in saying I have psoriasis and it's worse. You really need to look a little deeper. And then, of course, if it's infectious or non-infectious. And we will talk more about the life-threatening rashes. As I said, you have to be aware of them. We don't see them a lot. Sometimes we don't see life-threatening infectious rashes here in the United States, but just to be aware that there are some and what they look like. And then I mentioned there about, you know, actually your approach to looking at rashes. So it's either going to be fit into one of these categories, and these are the categories: either the petechial, that where there might be like a macular-papular rash, an ulcerative or pustule, vesicles, and then on from there. But the types of rashes, you will get more comfortable looking at them, and then that's how you'll determine and make your visual diagnoses. Okay, so now we're going to move into talking about some of the fun part of differentiating skin rashes and lesions. And differential diagnoses for dermatologic conditions are very, very broad. And so that's why in this talk we'll kind of approach it and talk about some of the common rashes that you'll see. And then as you can see from this slide, pediatric rashes are very, very broad and very, very common. And so you'll get more dermatology for peds. And then older adults tend to have some other types of rashes and maybe some of those worrisome lesions as well. And so you will get that part of it later in the program. So basically, your dermatologic conditions are based on the appearance of skin lesions. And that's why making visual diagnoses is so important. And as I mentioned, one of the fascinating things is that you could see a dermatologic condition in one patient and it could look slightly different than another. And so your eyes become your tools for determining what this condition is. There's also some conditions like psoriasis, for example, that you may be seeing the person in primary care. By the way, that's something that I always tend to refer because there's some underlying conditions. And now with some of the new injectable medications and so forth, you really want those patients to be seen by dermatology. But we're not going to talk about treatment and plans in here. We're really just talking about diagnoses. But it's very important to consider the dermatologic conditions and think about some of the underlying conditions. For example, with psoriasis, like psoriatic arthritis and so forth. So looking at the appearance, looking at what else is going on with the patient, your eyes become your tools to actually make the diagnosis. And so that's what we really mean about visual diagnosing. As I mentioned, one of the things that you never want to miss is a critical rash or a life-threatening rash. And I just put these in here because thinking from the emergency perspective, and even if you're in the ICU now, you've probably seen some necrotizing fasciitis, for example. If you've ever seen this, you will not ever forget it. The Fournier's gangrene I have recently seen, and it was an amazing thing to actually see the progression almost like right before your eyes. So it is something you would never forget seeing. I remember back to ICU days, and the necrotizing fasciitis is very, very difficult to treat, and obviously a surgical emergency. Steven-Johnson's rare but does happen, and you can have very minor symptoms to start with, and so that's something that should always be on your radar, especially related to drug rashes and so forth. So I put that here, the DRESS, and the calciphylaxis in end-stage renal disease, again, very rare, but something should be on your radar. And some of the other necrotizing rashes. Rocky Mountain spotted fever is not so much of a concern here, but in the United States it is, and it definitely, as you'll see from some of the photos, it could be difficult to diagnose. So you never want to miss that. You always need to talk to patients about their history, where they've been. Travel, of course, is a big piece of this, and I know that in talking with some students about travel health, that is something that you really want to get a good travel history, not just now because of COVID, but a travel history is so very important in all patients, especially if you're talking about a rash. Okay, so identifying some critical rashes, again, you're going to look for these petechial rashes that could indicate like a meningococcal infection, macular papular, again, that could be Rocky Mountain spotted fever, and that's a very common type of rash that you'll see. Your pustules like anthrax, obviously, again, you wouldn't want to miss anthrax, but again, these are the types of rashes that you're looking for, so they're common across a wide variety of rashes. Vesicular or blistering, again, those can be your necrotizing and your toxic rashes. And then Lyme disease with the serpiginous lesions, and then mixed, as you might see with Kawasaki. So I'm only bringing these up briefly here. You can certainly look those types of diseases up, and again, it's going to depend on your patient population, where they've been, and in perhaps where you're practicing. I do want to mention tick-related illness. It's so important in our area because we are in the tick capital of the United States in Middle Atlantic region. So you should definitely be aware of ticks, size of ticks, and as you can see in this picture, the infamous bullseye rash, which you rarely ever see, but if you do see it, it can look just like that. And when you see that, some patients will come in and say they have a bullseye, and it will look exactly like that. So always want to do a good full body scan, especially if they say they had a tick on them. Sometimes you'll never see the bullseye rash, so that's not always a presentation, but it could be. And then any other kind of rash with a related tick bite, you may consider treating for Lyme. Okay, so first we're going to start off with talking about infectious rashes. And I've listed them here, and these are very, very common across all age groups. Everywhere that you're going to work in primary care, you are guaranteed, I would say almost, probably guaranteed to see all of these. So these are a good way to start off with your visual diagnoses and get really good at recognizing these types of skin problems. Okay, so tinea. Most patients will come in and say they have ringworm. They just know they've had it before. Again, you want to do your vigilant history taking and physical, and then look and see. Now, there's all kinds of different tinnias. You will commonly see tinea corporis, which is on the body. You're going to see tinea capitis, which is the photo on the scalp. And then there's tinea cruris, you see in the groin area to the right on your screen. Tinea pedis, we see a lot of, that's your common athlete's foot. You can also see tinea of the nail, and then tinea vesicore, which is a body tinea, which can be also chronic. No matter where it is a scaly, itchy patch of skin. It usually has a circular shape to it, where there could be some thickening of the skin, and it's important to look for the well demarcated. You'll see a lot of documentation for this type of rash. It says well demarcated scaly itchy patch. Okay, so that's how you can differentiate it. It's usually with the tinea capitis, you usually do see some hair loss, and that is a good sign that what's going on underneath is tinea. And then there also can be some hypo or hypopigmentation of the skin. And again, you're just looking for your well demarcated scaling. And I should mention too with the feet, and that's usually not a difficult diagnosis to make, but there can be some white patches, and those white patches is really just the skin that has been moist and wet. And so on the feet, sometimes you will see more of, instead of dry scaling, you may see a little bit of more of a moist scaling, and that is part of that visual diagnosis. I just want to also mention for tinea, most people are a little bit embarrassed. They think it's, mostly related to poor hygiene. And, it can be poor hygiene, poor nutrition, just poor health in general. But people in warm climates or in the summer, we obviously see an uptick in this. And it's very, very common. So it's a very common fungal infection seen in adults and children. So it's definitely not related to only poor hygiene. Next up is another type of fungal infection, again common, and this you may see more in sometimes with diabetic patients. Other things may be going on. Remember, this is the same organism for oral thrush and vaginal yeast infections. So these are some photos of that. The photo on the left is a very obvious picture of oral thrush, but you can see this in all age groups as depicted here in the child, and it's usually in areas of folds. So under the breast, for example, under the abdominal fold, in the groin area, and people that are bedbound and children with diapers can also have these types of fungal infections, very hot, almost like we call them like hot red or red, very red and moist. So these are described as localized red moist areas of rash. Another very common presentation for children especially is impetigo. It is a staph infection, and these are some pictures of it. This is the same staph type infection that you might get with like a folliculitis, a cellulitis, and also your run-of-the-mill abscesses, although I would caution you most likely it's going to be MRSA if it's an abscess. So the picture on the left and the center picture of the children with these are very, very classic look of the impetigo with some crusting and red kind of pustule looking. Some areas may be of varying degrees of dryness, as you can see with the little hand there. Again, it's not uncommon to see in adults, but staph infections, obviously with MRSA infections, those are going to be maybe like the cellulitis or the abscesses, whereas in kids, you're going to see the impetigo around, mostly maybe on the face and in other areas. And scabies. So scabies is sometimes hard to diagnose only because you may not see the linear tracts, but that is what differentiates scabies. Scabies are intensely itching and it's worse at night. So that's the big clue for scabies. You will definitely see scabies in the web of the fingers. So if you see your preceptor or somebody looking for scabies, they're going to start off with looking at somebody's hands and look in between their fingers to see if they see any kind of rash or mite, MITE, track in that area. And the picture up at the top there under scabies, that's what the little microscopic mite looks like. You would not be able to see the mite, but visually. And then those tracks that are highlighted with the arrows are what it looks like as they track under the skin. They go under the skin and they burrow, and then they lay eggs. And so that is intensely itchy. Right now, and I guess, has been going on for a couple of years, are bed bug infestations. Now, it's important to note that if somebody comes in and you diagnose them with scabies, that room and or bed bugs, but scabies in particular, they can live for about 72 hours without human contact. So just because someone says, well, I haven't slept anywhere different or I haven't done anything different, they can still have scabies. So you have to look for that if they present with the very, very itchy rash, very intensely itchy at night, definitely in areas of warmth, like the crease of the elbow, for example, under the arm, in the groin area, and in the webs of the fingers. So again, vigilance and a good history. And I have the bed bugs there just as a comparison. So bed bugs aren't going to be this intensely itching. In fact, they may not even itch at all, but they're like bites that you can visually see. So that would be more like an insect bite. But the rash of the scabies is there. Okay, so moving on to herpes. So herpes simplex virus type 1 is a viral infection of the cutaneous tissue, and it manifests itself by vesicular lesions on the mucous membranes and skin. HSV1 is most often associated with the oral lesions, so cold sores on the mouth and the lips. HSV2 is associated with the genital lesions, so the virus appears in 3 stages. It can be primary, latent, or the reoccurring infections. And with the appearance of the viral infection, there is usually a incubation period of about 2 to 14 days. Usually vesicular lesions will appear. There's sort of a confluence of vesicular lesions. And again, by the time you might see them in primary care, they could be in varying stages of dryness. There's usually a red base. So primary lesions might be fever, blister on the lips. They can also present with some other viral type illness, like, for example, some fever and malaise. And then, as the blister becomes larger and it can be very painful, can also see them on the gum and the oral mucosa. I should mention, in terms of differential diagnosis with herpes simplex versus like impetigo, for example, you do need to look for like that crusting. So any kind of amber colored vesicular crusting over the vesicles would probably help you differentiate from herpes, where it's just going to be a red base and vesicles in varying stages of dryness. Kids a lot of times will come in as depicted in these pictures with finger herpes on their finger. It could definitely spread to the face and around the eye. If there is ocular herpes, that is an emergency, and if you think that someone has herpes either close to their eye or in their eye, they need to be seen by ophthalmology right away. Another type of vesicular rash is chickenpox and herpes zoster. So chickenpox is a very contagious infection caused by the varicella zoster virus, and it causes an itchy rash. It can be itchy, and it has small fluid-filled blisters. It's very, very contagious, but luckily there is a vaccine, and most children today in the United States are vaccinated for chickenpox. You will have patients that come in with herpes zoster outbreaks may say, well, I've never had chickenpox, but sometimes they could have had the virus that causes chickenpox, so they could have had the varicella zoster virus and just not had lesions that they noticed. These pictures here are very dramatic pictures, and just to show you what it looks like. But you can see that they're small pus-filled red base, and they can be in varying stages of dryness as well. But there are also stages. So the first stage might just be this small red bump, and people may mistake it for a pimple, for example, and then not realize they've had it. And so you can see this in varying stages. The two pictures on the bottom, to the right on the bottom, the older woman and then the person's leg, those are herpes zoster. And you may be more familiar with seeing that. And there is a vaccine now for shingles vaccine. But those can present in not always a textbook kind of an example of zoster. You don't typically see it on the leg, but it can be there. You typically see it on the trunk. You don't necessarily see it on the face and the neck, but again, it can follow that dermatome and present there. I've had patients with it on their arms, their limbs, which is a little bit more unusual. But it can definitely be there, and it doesn't always have to be painful either. So sometimes we'll say, well, if it's not painful, how can it be that? But it can be. And sometimes the pain can be delayed too. So, and then sometimes the pain can last way longer than the rash. And so for all those reasons, and it can recur. So they finish taking the Valtrex, for example, and then it comes back. And again, anytime you see this on the face, you have to be very careful that it is not spreading and it's not on mucous membranes or in the eye. So I put another vesicular rash caused by a virus into this visual because hand, foot, and mouth disease is very, very common, not just in children. You will see it in adults. This is caused by the Coxsackie virus, and it has vesicular lesions that present on the hand, feet, and oral mucosa. It can be very painful, especially when a child has this vesicle in their mouth or on their tongue, for example, as you see in the picture. There is no vaccine for it, and there is no specific treatment. You have to treat the symptoms. One of the things about this viral infection is that it really affects preschool children and children in daycare, for example, camps, and it can be seen in the summer and the fall because of school. It can also spread to family members, so that's how you may see it more in adult populations or people working with children in those areas. Basically, it can also be a generalized rash, and the lesions can be on the roof of the mouth. There can be lesions on the hand and feet and on the buttocks. It's very distressing for patients, and so that's why it's very common, but it can be very distressing. They can also have like some other symptoms, such as like a fever or feeling malaise or other viral type of symptoms, so they can just feel miserable with this. And it's very important to differentiate that and really treat the symptoms, because that's part of why this is very distressing. I've had patients come back again and again because it's very hard to manage, because like all viral illnesses, it can last for 7 to 14 days. And so after, the fifth day, they're not getting any better, and it's very, very painful with these lesions. They may come back. Basically, the best thing, I know we're not getting into any treatment, but because it's very distressing, you do want to reassure them, make sure that they are taking Tylenol, if they have a fever, and you do want them to call if it's not getting better after 7 to 10 days, so that you can make sure that you did make the correct diagnosis. But also, as I mentioned, it's really upsetting, and especially in that age of a child with that kind of pain. So make sure that they're taking something for pain. Okay, so syphilis is a bacterial infection. It's usually spread by sexual contact, and there's two parts that are dermatologic. So the first one is the initial painless sore. It's typically on the rectum, genital area. It's just typically on the genital area. It could be in the rectum or the mouth. And syphilis spreads from person to person via the skin contact. So you want to be on the lookout for the primary syphilis sore, or canker sore, for example. And they usually occur, as I mentioned, in the genital area, on the anus, or around the rectum, or in the mouth. And these sores are typically firm, round, and painless. And that is part of this whole differentiating, because it looks like it would be a very painful lesion, but it's not. And then secondary syphilis is when you would see the rash. They may have more of a viral or more systemic symptoms, like a fever, or feeling or having some swollen lymph nodes, for example. And that is stage 2 doesn't happen for 8 to 10 or 4 to 10 weeks later. We usually think like 8 weeks later. But this is where you can see a full body rash. You may see rash on the hands, and a lot of times this may not be itchy either. So it's just this kind of rash that could be very mild, and it may go unnoticed. And so that is why any kind of physical exam you're doing, you really want to pay attention for any rashes. So you may or may not have symptoms with this full body rash. It may not be itchy at all, though it looks like it would be. It's not. So, and most time, this is how syphilis is diagnosed. It may not be diagnosed at stage 1, therefore it's not treated. So it progresses to stage 2, and again, it may not be picked up. So again, vigilance in making this diagnosis. And then, later syphilis in the tertiary stage is a much more severe medical problem. You're not going to see the rash at that point. So you really want to catch it stage 1. Look for the sore. In sexually active, do the blood test to confirm. And then if you see the rash later that doesn't look like any other type of rash that you've seen, test for it. Do the RPR and make sure you catch it at that point. Now, I did put gonorrhea here just to remind everyone that gonorrhea can be an infection in the genital tract. It can be anal and rectal, and also oral. So it's important to, again, be vigilant about that. If your strep culture for that throat, the tonsillitis or pharyngitis that you're seeing there, just send the throat culture, because a lot of times that is how gonorrhea will be diagnosed. You can see sores because, again, it's an infection, so it may not necessarily present with the pustules or any kind of sore. It can also be ocular. So again, you need to be on high alert for some of these other skin problems that could be related to gonorrhea. Okay, so now we're going to move on to non-infectious rashes, and I have them listed here. And these are very common presentations for skin problems in primary care. And some of these you will want to refer right away, and many of these are managed in primary care. So again, these, if you can focus on these right now to really get familiar with, if you probably have seen quite a few of these already in clinical, but we're going to go through them as well. Okay, so let's start talking about eczema. This is one that you'll see a lot of variation in clinical practice. It's a pattern of skin inflammation, and it has clinical features of lichenification, which is the lines or the cracking. Also has erythema, itching, can be scaly, sometimes can have pustules or vesicles as a combination. And right now the term eczema is used interchangeably with dermatitis. And then the most common variant is an atopic dermatitis. So overall, this is very, very common. Eczema is about 1 in 18 in 1,000 in the United States. And about 60% of those with atopic dermatitis are affected by both between infancy and the age of 12 years old. And it's a little bit more common in boys, but approximately 20% of children and 3% of adults are afflicted with eczema. So you want to really get a good family history, and you'll hear clinical folks talk about atopic. So a child they may say is atopic versus being completely or fully diagnosed with eczema. So atopic refers to a tendency towards, like dermatitis, rashes, could also be testing more for asthma, and may also be presenting more with allergic rhinitis. And this atopic presentation is also very common without finding that the child has eczema. And I remember my son to this day, he's 20, is still very atopic. If something just that is irritating touches his skin, he'll have a full-blown reaction. He had it to crayons. There's a lot of things that can trigger it. In children, and then he kept getting tested for asthma because of the how atopic he was. So you'll see that a lot next semester, actually, in peds. But when there are plenty of adults that you will see with eczema, and also nurses. So nurses, because of all the skin, the gel, the hand gel. More frequent hand washing and soaps, and different soaps depending on which units they're on. Nurses a lot of times will have or develop eczema of the hands. Okay, so anyway, this is very, very common, and you'll see a lot of itching, dryness, a lot of discoloration or scaling, and in these really chronic areas that you can see down on the right hand side on the wrist, they can be, the skin can have some changes with some skin thickening. And the other thing to really watch out for is that because of the scratching, sometimes it's very, very intense. You want to treat them with some kind of topical steroid cream to cut down on the itching, because they can scratch so much that they have an overlay of a bacterial infection. So then you would have to treat it as more of a cellulitis. But anyway, it can also be associated with some bleeding because of the cracks in the skin, and then some oozing or some serous fluid. Okay, another very common dermatitis that you'll see is contact dermatitis, or allergic. You'll hear it called allergic contact dermatitis, and that is when the skin becomes red, itchy again, very itchy, and it's caused by direct contact with a substance or an allergic reaction to that substance. So, for example, poison ivy, poison oak, poison sumac. So they are also these allergic contact dermatitis can also arise from some soaps. So you'll hear clinicians ask, have you changed anything? So laundry soap is a big offender. Sleeping with sheets that were just washed by some different laundry soap. Fragrances, a big offender. So fragrances that they may put on their skin, or that are in other products. So like lotions or soaps. So any kind of personal hygiene product may be the culprit, and of course plants. And then, as you see in the top left corner, that is an allergy to a piece of jewelry, a ring. And some people have very, very severe nickel allergies. A lot of times in the ER, we will have young females come in because they have just gotten a piercing in their ear, or anyone with a piercing that now has a contact dermatitis and wants that piercing removed because it's very uncomfortable. And it's not necessarily an infection, although it could be, so you have to rule that out. But it's from an allergy to perhaps nickel or the metal, and it's a contact dermatitis. You will also see a lot of contact dermatitis now with the eyelash glue. So gluing on of eyelashes has become a frequent visitor in the urgent care, and the only solution to that is having to take them off and get the glue off. So we typically don't do that, but they have to go back and have the eyelashes removed. And again, you would have to be, I know we're not talking about treatment, but I just feel like I need to say you have to be very careful with any kind of steroid cream on the face, and especially around the eyes or on the eyelid. Now you can get poison ivy on the face, and the bottom right hand picture is that. It's contact dermatitis on the face. So if you're, have contact with the plant and then you rub your face, very, very common. See that a lot in occupational situations where there's tree cutters or lawn yard work individuals who will come in contact with it and have it on their face. And again, this is a rash that will vary widely. And again, you want to prevent a secondary infection, so being careful to really treat well and stop the itching. Okay, so moving on to psoriasis. So psoriasis is very common, again, a common benign chronic inflammatory skin disorder. It's usually familial, and psoriasis is categorized by this whitish scaly patches, and most of the time you'll see this on the scalp, the knees, and the elbows. In total, psoriasis affects about 7.5 million people in the United States, and most of the vast majority of the psoriasis that we see is 80%, would be 80%, and it's plaque psoriasis. And it usually occurs in adolescents, and it's seen in young adults and, of course, in older adults. I have a lot of personal experience with psoriasis because my husband has psoriasis, and I can tell you that it's one of the skin disorders that is very upsetting to patients. So if they have even a small plaque, like for example in the top middle picture, that might be the only plaque that person has, but it's there, and they want to keep it covered. Even if it's on their shin and they don't necessarily wear shorts all the time, it can be very upsetting and really affect someone's body image. So a word of caution there. So early referral to dermatology for psoriasis is very important. You can have psoriasis in the nails. I put a couple different variations here. You can have all over body psoriasis. Psoriasis can be on your face and your scalp, which can also be very upsetting, and people tend to want to stay covered up. Check for a family history, and then also make sure that you're talking to the patient about other symptoms. So psoriasis has been linked to heart disease, for example, psoriatic arthritis, where you're seeing very distinct changes in joints of the fingers. So again, assessing all of that is very important. But just the skin part of it, you're looking for these dry, scaly, patchy rashes. And sometimes it can be itchy, especially if it's a flare, for example. And again, that can lead patients to become very itchy and scratch it, and then have a secondary infection. Sometimes these larger chronic plaques they'll show up in older individuals, and then they're a little bit harder to treat with some of the topicals. So I know we're not talking about treatment, but I just want to say that depending on the body area, there can be various treatments. But now there's some really great new injectables. So again, early referral for psoriasis. Okay, so now we're going to talk about drug eruptions, and these are adverse skin reactions to medications or other supplements. It does not have to be a prescribed medication. I have seen drug eruptions from, new supplement, new vitamin E, you name it, people can have a drug reaction. They can also have these reactions even if they've taken the medication before. Some of the common culprits would be a Bactrim, for example. Couple days into treatment, and they're back with a drug rash. Other very common causes, antimicrobials, of course, the sulfa drugs, as I mentioned, NSAIDs, and some chemotherapy agents, anticonvulsants, and psychotropic drugs. So again, very tricky. I know not to get too far into pharmacology here, but the Lamictal, for example, and the itching and the skin reaction with that, they need to stop immediately. And usually in primary care, that's what we'll say. If you're on call and you get this, you would really want somebody to check this out. This would be difficult to really look at on telehealth, but we do. But you really need to look at the trunk, look all over. And then, of course, if there's something that the patient started to take, by way of, history, you could determine that this was a drug eruption if you're looking at these type of rashes shown here. And remember that the drugs, that the reaction can be in any part of the skin. So I have another example about my son. He had an allergic reaction to amoxicillin. I forget exactly what age that was, but that was, he was fairly young. And he had a reaction, but we didn't know it was amoxicillin. I thought it was I really wasn't sure because it was just his scalp. And his scalp became very red and inflamed and, I guess looked like more like the top pictures there. And it was itchy, and it was just like, I didn't really know what the heck. So he had eaten a big bowl of strawberries, and then he was taking amoxicillin at the time. And we wound up at CHOP Allergy and, the whole workup and everything. And they determined that it was a reaction to the amoxicillin, which then, again, later he was able to be desensitized to that. So, just because you have an allergic skin reaction doesn't mean you can ever take it again. And amoxicillin happens to be one of them because, penicillin is a great treatment for many, many things. So if you ever have anyone in that situation, they can be desensitized and take that medication later in life. But anyway, the skin reaction can be anywhere. So I tried to put that here. I didn't have a picture of a scalp, but remember that a drug reaction can certainly start and only be in certain areas of the body. Okay, and rosacea is another very common skin disorder, although it does not affect children. It is seen primarily in all ethnic backgrounds, but most frequently observed in people with fair pigmented skin. And it's a multifactorial vascular skin disorder, often called acne rosacea, and it's characterized by chronic inflammatory process in which flushing and dilation of the blood vessels occur, mainly on the face. It is basically this flushing and dilating, which then can be also triggered by immune system and exposure to UV light, heightened activity where there's like a vascular dilation, and other involvement may include the eyelid and also the conjunctiva. So the hallmarks of visually diagnosing this would be the small papules and papule pustules, and they may present with these erythematous papules, and they might have tiny pustules at the crest. They really don't develop into like big pimples, and they don't usually start as like a pimple looking or a blackhead type of presentation. And there can be this intermittent also reddening and flushing of the face. And people that are prone to flushing or have a tendency to flush frequently, have more of a red experience, can also happen if they have hot or spicy food or alcohol. So that's why a good history is important, and then look for signs. Now, sometimes with this, you do need to refer if you're not sure. Sometimes it can be treated with steroids, but sometimes you want to do a skin biopsy to rule out other things like lupus or sarcoidosis. And again, you would want to differentiate between regular acne, and again, that would be age determinant. But remember that this is usually, age adults, common in adults, but not typically seen in children. Okay, and hives, again, any age group, you see this widely as a reaction. But it can also be chronic and idiopathic. So, and people will know if they have this chronic idiopathic urticaria. But basically, hives are, urticaria is red, itchy, they're welt-like, and they result from a skin reaction. It can be either to something ingested or that touches the skin. Again, those very atopic patients could wind up with hives. But it can also be an allergic reaction to something that is taken by mouth or ingested. That's why you'll see people want to give Benadryl right away, Benadryl and Pepcid, to block both of the histamine reaction. And usually when the reaction runs its course or is treated, they will just fade away. And they can be very upsetting. You see the little girl in the middle, because they start to really itch. And if you've ever seen a child come running in, as I have in the urgent care with a peanut allergy, usually the hives are the first thing you see, and then it can progress. So it can be very upsetting, very itchy. And there's just some of the patterns and pictures of what they can look like. Okay, and finally we're going to talk about good old dry skin or xerosis. Now, sometimes this can be related to an atopic dermatitis, but many times you will see just dry skin in the very young and the very old, or I shouldn't say very old, but older adults tend to have this problem. And they may come in because it's itchy, but it really can just be dry skin. And I'm thinking about many of my patients right now who I see that are homebound elderly. They may not be able to reach their legs in all, full disclosure, to put lotion on, but their legs can look like that desert picture down there. And it can be very itchy, and then they can crack and lead to, superficial infections, which for diabetics, that's a problem. Especially with feet, can be very dry, bodies, as I show in one of the pictures here, and their skin can really look that cracked and dry. So you're looking for, all areas of the body, definitely looking for any kind of plaques or erythema to rule out other possible skin problems. But the skin can appear very dry. It may have fissures. Many times it has fissures. Can be shiny or cracked, and you can see some inflammatory changes or some skin thickening. So again, very important. I know we're not really talking about treatment again, but I just want to mention how important moisturizing from the inside with water intake and moisturizing from outside with lotions and some lubricating and hydrating creams, for example. So not to be a commercial for any one in particular, but Eucerin tends to be a go-to, as well as Curel. And Curel seems to be very well, it seems to really work well, and has varying formulas for like anti-itch and so forth. So sometimes that's very helpful, but also good old petroleum is very helpful too. And people will appreciate that and feel better really quickly. So you probably would want to see them back and make sure that's working. This is one you could, treat yourself and see how it goes, and make sure that there's nothing else going on once you see the patient back. But again, very important to remember that dry skin can present as a rash, and it's just something that needs to be treated topically and with hydration. I thank you for listening, and although this is the end of this guideline on visual diagnosis of rash, this is only the beginning for you. You will see a lot of people in a lot of places with a lot of different rashes, and so this will be an ongoing learning opportunity for rashes and making visual diagnosis. Thank you again. And if you have any questions, please feel free to email me. I'm happy to talk about any rashes or other skin problems.